I'm going to start with a video that we took when Gabriel was a day old.
We've got him off the dopamine now.
That's what Mary was saying. That
yes, and that means his heart is keeping his blood pressure up at the right level by itself.
Okay.
And his blood is a little on the acidic side, so giving him sodium bicarbonate for that.
Already he's getting baking soda, huh?
Yeah, and he's been getting a lot of transfusions lately, just because, well, his body only has about 3 tablespoons of blood in it.
Is that all?
Yeah.
3 tablespoons, wow.
Yeah.
Okay. Now when I show this video at nursing schools, I start the presentation this way as a means of keeping their attention, so as to say, well, what happened after this? With this group, I can't really do that because the child in this video is raising his voice to the Lord at the most inopportune moments during the liturgy. So, and then another difference between doing this presentation at nursing schools and medical schools is that here the more apt presentation, I suppose, would be about how to support families in crisis, and what an amazing job this parish did for us. But I'm not going to talk about that because the main reason I'm having this presentation today is practice for my own public speaking abilities for the nursing school presentation I'm giving this week in Spokane. So, that video, again, was taken at when Gabriel was 1 day old. The 2 voices there are mine and my father's as we're taping Gabriel. And we made the video so we could show it to my grandmother, who was not going to be able to travel to the NICU. And it was at the time we took it, we thought, oh my goodness, are we ever going to show this to anybody? It was so frightening to us. And in the video, he's on a ventilator. He's on umbilical catheters, meaning that they've got tubes into where the umbilical cord used to go to provide him some amount of nutrition through there. The blindfold that he's got on is to protect his eyes from the special light they were using. It's called a bilirubin light, which is meant to break down toxins in his skin that his liver was not able to break down. So this is at 22 weeks and 6 days of gestation, shortly after he was born. Yes?
Has he got actual dark red color, or is it?
That is correct. That is the color that the preemie's coming out looking like at that stage. About the color of a cooked lobster and about the size of one, too. So, to step back about a day in time from when that video was taken, was the conversation that we had with the neonatologist, a neonatologist is a pediatrician who specializes in preemies. And what he said at that point was, I don't recommend that babies should be treated at this stage because the results are so poor. If you give birth after midnight, I'll be the one who comes and does the resuscitation, but my heart won't fully be in it. That was his recommendation. The part about midnight is simply that the hospital and this doctor had a standard that babies should not be resuscitated before they reach 23 weeks and 0 days of gestation at that time, believing that it was not ethical to try to resuscitate a child before that because of the poor survival chances. So the question, the first immediate question that came into our minds and anybody else's mind is, can he do that? We were very adamant that we did want to have resuscitation, but the doctor was saying at first he wouldn't do it, and then he was trying to talk us out of doing it. So, what we have here is clinical guidelines from the American Academy of Pediatrics. And it's giving reasons here. When gestation, birth weight, or congenital anomalies are associated with almost certain early death, and when unacceptably high morbidity is likely among the rare survivals, resuscitation is not indicated. And not indicated in medical speak means you shouldn't do it. Examples include extreme prematurity, gestational age of less than 23 weeks, or birth weight of less than 400 grams, anencephaly, and some major chromosomal abnormalities such as trisomy 13 and some specific specifications about that. Now, Gabriel was born at 22 weeks and 6 days, so he was just under this line that was set up. And he weighed 652 grams, which is almost 1.5 times larger than the standard. And that put him in the 97th percentile for size at his birth. They blamed that on me, if you can imagine.
That's right.
And so, anyway, so that doctor, as much as we disliked his recommendation, what kind of crazy thing are you saying? His recommendation was in line with national standards at that point.
Can I ask a question?
Yes.
Is that based on a study? How would they know this would not be the thing they should do?
Well,
They've never done it before, obviously, right?
well, at that particular hospital, I don't know if they've ever, I think that was the first 22-week infant they have resuscitated. There have been other infants in the 21st week and the 22nd week who have been resuscitated around the country, and the results are generally rather poor. And so this is a document that gets reissued every 4 or 5 years with new standards. That was the 2010 version, which was in effect when Gabriel was born in 2012. So then the next question that comes to mind is, why would this doctor say such a thing? And I have some statistics here of outcomes of infants born by the gestational week at which they're born. So in the 22nd week, 63% of infants, or of neonates in this study, died before they could leave the NICU, and 73% either died or had profound neurodevelopmental impairment. And profound is the highest level of neurodevelopmental impairment, and so that was a primary reason they were recommending against it, is that the outcome of treatments was going to be poor, so it would be more compassionate to deny care at the beginning than to try to save the child, was the argument. And as you can see with this chart, as each week goes by, the chance of survival goes way up. In the 23rd week, 35% of infants died. In the 24th week, 22%, and the 25th week, 14%. These statistics are from a study done in Japan. I'm using Japanese statistics because the Japanese have been routinely resuscitating infants in the 22nd week since the 1990s. Here in the United States, it's been much foggier as to whether infants should be resuscitated in the 22nd week or not. They gave us statistics to look at before the birth that were much gloomier than these. So let's talk about futility. Physicians are not required to provide care that they believe is futile, meaning care unlikely to benefit the patient, or treatment to provide poor quality of benefit. And to define that second one there, treatment to provide poor quality of benefit. For example, if a doctor is providing resuscitation to an adult, and there's say resuscitation's gone on for 15 minutes or 20 minutes, and the patient has not shown any signs of spontaneous heartbeat, you can say, well, we could continue for another 5 minutes, but then if on the off chance the patient did self-recover, he's almost certain to be brain dead. And so that would be a poor quality of benefit at that point. And so the doctor has to have a time at which he says, we're going to declare the patient dead, he's unresponsive. With this question of a preemie born at the edge of viability at 22 or 23 weeks of gestation, there's a time crunch also complicates matters, because the baby is just fine before birth. There is no way to determine which child is going to survive, which one is not. And the futility is over problems not yet experienced by the child. However, at the birth, it's very difficult to make all those decisions while everybody is rushing around the baby, putting in tubes and things like that. So they ask the parents to make a decision before the birth about what kind of treatment they want for their child. The doctor pointed out that resuscitation was an all or nothing kind of proposition. The resuscitation went way beyond standard CPR and involved a tube down the throat, lots of uncomfortable tubes, IV catheters, wires, things like that. So you can look at this moment as something that bioethicists have called a window of death, meaning a time when you can take action that will result in the death of a patient. It may not be that you are directly causing that death, but by not providing the treatment, it is possible. Your actions are likely to cause this death. And so when you have this kind of window of death, you ask yourself, what is the intent of your action? One thing that was on our minds was that in this country, large numbers of disabled children known to be having a disability in the womb are aborted. In fact, 67% of babies who are detected to have Down syndrome in the womb are aborted in this country. So, you know, is that a similar decision like that? Is that your intent? Are you walking away from a potentially disabled child? Are you taking advantage of the disabled at their weakest moment? Or are you reducing the suffering of someone who is likely to die? We felt that we had a duty to protect our son, whether he would be disabled or not. When medical ethical texts talk about this question, the two aspects that they're trying to balance are the autonomy of the patient versus beneficence. Our child was autonomous, just barely, in that he could survive outside of the womb, but then the question is, what is to his benefit? Is it more to his benefit to try to save him so that he can live a long life, or is it more to his benefit to reduce his suffering, especially for a person who is likely to die? And consider this in two examples of adult care. If you have a breast cancer patient with a 30% chance of survival, what if the doctor goes to that patient and says, no, it's not worth it, we're not going to provide care? I think that doctor would have some pushback from the patient and probably from the community as well if he took that attitude. Or conversely, what if you told adult patients that you have a 30% chance of survival, 5 months of uncomfortable treatment, and disability is very likely after if you survive? Will all of those adult patients say yes to that care? I don't know if I would say yes, which in some regards is a troubling aspect of our decision to resuscitate Gabriel. And that, thankfully he doesn't remember, at least we don't think he remembers the things that we did to him in the NICU, but, is that the sort of thing a person would want to go through? Another aspect to think about with this is how low is too premature. Eventually you are going to hit a wall where it either is hopeless or nearly hopeless. I talked to a doctor on the phone last week from Florida who said that he's had parents come in at 20 weeks of gestation when no child has ever survived at 20 weeks. And where parents have asked for resuscitation at 20 weeks. And the doctor has had to go against the patient's wishes in that case. He's also had parents at 28 weeks begging for no treatment at a birth. And at that point, he says he has to go ahead and provide that treatment because survival rates are in the 90% range at that point. So it's a difficult place for the doctor to be in. The religious beliefs of the family, or the beliefs about, or for secular families, their beliefs about what amounts to quality of life. Our belief was that life that only lasts for a few days is beautiful. It glorifies God, even if it includes suffering. It felt to us like the doctor was pushing sort of an alternative utilitarian religion based on his ethics to reduce Gabriel's suffering. It might be a little unfair to say such a thing, but then when the life of a family member is on the line, the separation of church and state that we sort of use to relate to the non-religious world, it breaks down. That it's like, no, actually you are assaulting my religion when you tell me to do this thing. Let's see. I also want to talk about the statistics that are provided to you when, or that were provided to us when we were in the what's called antenatal counseling just before birth. They provide counseling about the neurodevelopmental abilities of babies who are studied 2 years later after they come out of the NICU. And the categories they provide are unimpaired, moderate to severe neurodevelopmental impairment, severe to profound neurodevelopmental impairment, and death before leaving the hospital. So we found these somewhat helpful, but again, they're kind of poorly defined, and I'll get into that in a minute. When Gabriel had just turned 3 years old, we wrote a letter to the ethics committee at Swedish Hospital advocating for them to do some different things in the way that they approach antenatal counseling. They started off by telling us that the thing that they're after most is informed consent from the parents, meaning that they want to provide as much information as is necessary to get the parents to be willing to say yes or no in an informed manner. And they said, well, we don't want to push, it's too bad that you felt pushed to not have resuscitation, but then there's lots of other families who are looking to let go at this stage, who feel everything's falling apart and they just need to let go. How do we not be pushing either group to do a decision that they don't want to make? I suggested an opening line should be, your child is welcome in our nursery. Doesn't introduce bias, but it does, it does several things. One is it identifies the child as a person, which is something that was very frustrating to us during that meeting, in that, especially to Miri, in that they were treating our child as a medical condition, primarily as a statistic, and he was not getting spoken about as a child, and we had picked out a name at that point, but he wasn't getting referred to by name. And once that decision is made, the hospital makes a strong effort, and once the decision on a course of care is made, that it should be fully supported by the staff. And at that point, they apologized to us for saying that our wishes were not fully supported, and that we had to fight them on more levels than just asking for what we wanted. I suggested in this meeting that they ought to use more local statistics about their specific hospital rather than just the national statistics, to get a less intimidating view of what could happen. And at that point, the doctor said, well, we could say that our NICU has a 100% success rate with 22-week preemies. And then I said, okay, I see your point. I smacked my head because, you know, Gabriel's the only one that they've had. So that's not going to work. I also advocate